Hi, everybody. Okay, now that we have foundations of corrective exercise and the need for this class, I want to talk about the origins of movement dysfunction, because if we want to know how to fix things, we have to know what's going on in the first place, right? And we need to understand some neuroscience behind that. And so I want to talk about that. Let me get my pointer out here real quick. I want to talk about the neuroscience of kinetic chain dysfunction, and particularly muscle imbalances. Remember, this is review. In order for movement efficiency, muscles have to be cooperating in force couples, paired relationships that ensure dynamic stability and proper postural mechanics, and then therefore proper arthrokinematics of the joint. That leads to a stable joint with movement efficiency. But things go wrong, right? Some of you probably have seen this in the literature. What are you looking at? You're looking at the most common movement dysfunctions identified by a neurophysiologist, Vladimir Yanda, and other folks have used it. But really, these movement dysfunctions are part of what the NASM corrective exercise model is based on. And so I'm not going to spend a lot of time in detail here. What I'm just going to tell you is these patterns, you see here an X or a cross, it's a cross syndrome. So these patterns are the predictable patterns of dysfunction that people most commonly fall into. And there are three of them, just to make it simple. There's an upper cross syndrome through the cervical spine, the shoulders, and the thoracic spine. And then there's a lower cross syndrome through the core, abdomen, lumbopelvic hip complex. And then there's a pronation distortion syndrome from the subtalar joint through the knee and hip. Okay, so those three movement dysfunctions essentially are characterized by the word dysfunction implies that muscles are not coordinating to drive joint mechanics. And really that's the essence of it. And we'll unpack all of that as we move on into the course. And so normally, you all know this, muscles act in force couples, which are paired relationships, like we said, between an agonist and antagonist. I actually don't like that terminology, but that's what most anatomists and physiologists use. I prefer to think of synergists. If my hands are a muscle on the anterior side and the posterior side, when they move together, they're moving in synergy to permit smooth motion. But anyway, let's use the agonist-antagonist example. So here you see the abs maybe, and the glutes or the erector spinae at the pelvis, or the quads and the hamstring, right? These are force couples, paired relationships. Or here, what would we say? Tibialis anterior and maybe gastroc, or tibialis posterior. Think about them operating at a joint on one side and the other, and the joint itself, right, is an axis of rotation around which motion happens, right? And so if we think of the entire body that way, these synergists are acting to stabilize joints. Okay, and the second point here, and it's a big one, clinicians should assess these relationships because, let's say, for instance, the pelvis. If the pelvis is anteriorly rotated, you know that these front muscles are tight and dominant, pulling the pelvis forward. Well, what would those muscles be? Iliopsoas is the first thing that comes to mind. So clinicians should assess for a dysfunction like that. That's just one example. Because that's a kinetic dysfunction, and that's going to disrupt normal force couples. That's going to throw off efficient movement. That could potentially lead to pain and injury. So these imbalances, these muscle imbalances, are the foundation on which movement dysfunction is based. Okay, in other words, any postural dysfunction probably has a muscle imbalance as a primary cause. At least that's what most movement like scientists say, and we'll get into that. And then we're gonna get into these subpoints, so I won't say it now. Okay, so structural and functional approaches. There are two basic approaches to these muscle imbalances. So we're continuing on with the idea that muscles, when they're not acting correctly in force couples, they're imbalanced. And so there are structural and functional reasons for this. And these aren't at odds with each other, structural and functional. In fact, what we're going to learn is both of these types of dysfunction are seen clinically, but throughout history, two schools of thought on muscle imbalances have existed. The first was structural, so Kendall back in 1993, and then Sarman, some of you probably have heard that name. Lots of people on social media, et cetera, will quote Sarman. These are both legends. Kendall, you might have read her book, Muscle Testing and Function, or Muscle Structure and Function, I think. No, it's Muscle Testing and Function. It's a classic physical therapy text. She's considered the mother of physical therapy, by the way. But she and Sarman have a more traditional biomechanical approach to muscle imbalance. In other words, there's a biomechanical cause resulting from repetitive movements or postures. So postural syndromes have biomechanic causes. And of course, we would say that's true, right? That's what we've been learning for years in our education. Well, then Vladimir Yanda, he's a neurophysiologist. He did a lot of EKG studying where he was hooking up muscle and determining the actual physiologic process whereby muscles are contracting. And what he found was very interesting, where a lot of times when his patients that he studied when they had pain, he would find a very predictable pattern of muscle weakness in one agonist and then muscle inhibition in the antagonist, okay? And so both structural and functional approaches we see clinically, so it's important to understand both. Here's Yanda's book. I'll give you a PDF of most of the book. I really have enjoyed, this actually isn't Yanda's original book. It's three folks who wrote a book based on his work, and it's a really good approach. I would highly recommend it. I'm going to do that to you a few times. I haven't required this text, but if you want to go deeper into what we're talking about in the next 20 minutes, then this book would be something that you pick up, and it's not very expensive. Okay, let's talk a little bit, and I wanted to give you an example of this biomechanics approach to muscle imbalance. So here on the right, we see the typical upper cross syndrome with a forward rounded head, a chin sticking out, and forward shoulders, right? And we're seeing this more and more obviously as we're part of the texting and the phone generation that's unfortunately, most of us don't hold our phone up high to where it's parallel with our eyes. So we have repetitive, kind of static, sustained posture through our everyday activities like, our news feeds on our phones. This leads to a predictable adaptation in muscle length. So that literally, what do I mean? The deep flexors of the neck on the front of the neck get tight, right? And then the extensors on the back of the neck, extensors here, are trying to correct and pull the head back forward. But you see here, the normal head and neck is 12 pounds all the way through the cervical spine and head. But the more you've got to fight against gravity, the heavier the neck becomes and the harder the extensor muscles have to work. But what I'm saying here is the altered synergists and agonist-antagonists, the altered movement is that as we have sustained posture with neck forward, the muscles on the anterior side shorten and they become tight and dominant. And then the muscles on the opposite side become the opposite of that. So they become weak and inhibited and lengthened. And when they become lengthened, their ability to generate force is decreased. Okay, so this is a predictable pattern of kinetic dysfunction. So our treatment approach should be to identify the muscles, identify these patterns, identify the tight, dominant, overactive muscles, and inhibit them, and then restore precise joint motion by shortening the longer muscles and strengthening them. So that's the whole idea on which the corrective exercise paradigm is built. But what I'm showing you here, and this is part of your graduate degree, is I'm showing you the foundational science, okay, on which your textbook is built. So here's Yanda's approach. It's a neurologic paradigm again, because he was a neuro guy, but he changed the paradigm to more of a functional. And so let's spend a little bit of time here, and I apologize if I geek out a little bit into the central nervous system, but I think it's very important, and I didn't want you to miss out on this. So Yanda really proposed that muscles are more than origin and insertion, okay? So I think and here I'm on my soapbox a little bit. I think particularly the American system, when we learn anatomy, we sort of learn this cookie cutter, this muscle does this. And really what we're learning is the concentric action, right? The concentric kind of uniplanar motion of muscles. And anybody who's walked around and studied the human body enough, for more than just a couple days, knows that muscles are more than just origin and insertion. They're more than just uniplanar concentric action, right? They're concentric, eccentric, econcentric, they're triplanar. And so, and muscles move and stabilize and decelerate. They don't just contract and shorten. And so Yonda really pushed our understanding beyond simple muscle function. And so he said muscles function in synergies. We're going to talk about anatomy trains in a little while. And I think when I think synergies, I think anatomy trains. And really they interact and they're interdependent with each other to coordinate global movements. Okay, so Yonda believed that joints, muscles, and the central nervous system are functionally integrated. They're all part of a sensory motor system. And so we're going to talk about that in just a minute. And the second bullet point there, any change in a muscle recruitment of an individual muscle alters the balance, not only at that joint, but within a movement pattern. So I'd like to tweak our brains to think in terms of patterns. You might have learned this in undergrad, but there's a axiom called Beaver's axiom. I think it was the guy's last name. It's an unfortunate name, but Beaver's axiom is the brain knows not of muscles, but of movement. In other words, your brain isn't up there central command saying, okay, flexor digiti minimi, contract. It's saying, no, we need to feed ourselves, right? And so the brain doesn't know of individual muscles. It knows of movement patterns to accomplish efficient movement. So I'd like us to think that way, movement patterns, not individual muscle function. That's a neurophysiologic way to think of it. Okay. And what I really want us to know, there's a lot of words to tell you that this thought process is the foundation for the NASM model that we're going to learn, and for FMS, which assesses and screens global movement. Okay, and so it never hurts to quote Aristotle. He said, "We are what we repeatedly do. Excellence then is not one act but a habit." So, I mean, the application here though is that if we train movement patterns, then our clients and patients become better and more efficient at movement patterns. And they are what they repeatedly do. So we need to train good and proper movements. Okay, I'm going to take you back into probably a motor learning and motor control class that you had in undergrad, but I think it's important as a foundation. So the human brain operates through the sensory motor system. Sensory motor, sensory being afferent, motor being efferent, right? So the entire system is a looped system whereby the brain takes in information. I feel like I need to see you guys for this. Whereby the brain takes in information through somatosensations, so proprioceptors, mechanoreceptors on the skin, in the inner ear, in the vestibular system, and through balance in general, right? So it takes in all this information on temperature, on pressure, on mechanical strain, afferently, and through the eyes. That's the other part of the sensory motor system that I was forgetting. Brain fart there. And then it integrates that information up in the somatosensory cortex, right? And then that's grand central station. Grand central station is through the thalamus to the somatosensory cortex, but then the cortex decides, what am I going to do with this information, right? So if it's a painful stimulus, we have a withdrawal reflex, right? If it's a mechanical strain through the anterior talofibular ligament, let's say, and the ankle, we contract the peroneals so that we don't invert and sprain our ankle. This is the sensory motor system, and we need to remember this as we talk about muscle imbalance. And so that response after the somatosensory cortex in the brain figures out what to do, it sends an efferent command, right, down this descending track to that muscle that says, you need to act so we can get out of this mess, so to speak. That's sensory motor system 101. Okay, so let's talk about one of the most important slides we can talk about in this short talk. how do muscle imbalances begin? Well, this is a paradigm that I came across in a physical therapy textbook, and I really like it. So if we had an hour just to discuss this in person, I would break us up into groups, and each of us take one of these numbers and we explain it, because it kind of goes systematically, but I'm going to talk us through it. So the question being for this paradigm, how do muscle imbalances begin, and what do they look like? Okay, so remember our biomechanical approach. Prolonged postures or repeated contractions in muscle develop postural dysfunction because those muscles become tight and dominant. Really, from a neurophysiologic standpoint, there's increased alpha motor neuron pool excitability. I know I told you I was going to geek out on you a little bit, but increased excitability, right? As the brain keeps stimulating those muscles to repetitively do what those muscles need to do. You think of the thrower, all the anterior musculature on the thrower to get velocity. Those are heightened, those muscles. They're also prone, what I'm saying to you here, prone to tightness and dominance and overactivity because of the increased neural drive. Okay, that's step 1 and 2. So muscles that repetitively contract are prone to tightness and dominance. Okay. Do you remember reciprocal inhibition? Let me teach it to you really quick here. Remember reciprocal inhibition. Well, let's learn the stretch reflex really quick. I know I'm going entire undergrad on you. So when a muscle is stretched, here on the left side, this is the stretch reflex. Here on the right side is reciprocal inhibition. So the classic example of this is, say you go to the doctor wants to check your patellar tendon reflex, right? Taps your patellar tendon with a reflex hammer. What happens? Well, very quickly, what happens is, I'll explain it from both sides of the model. What happens is the quads, through the quad tendon, get stretched. The muscle spindle afferent senses the rate and magnitude of stretch in a muscle. It sends an excitatory impulse to the spinal cord. The spinal cord has an interneuron with which that muscle spindle afferent synapses, right? The muscle spindle afferent synapses with an efferent motor neuron, an alpha motor neuron here. What does that motor neuron do to the muscle? The muscle is just rapidly stretched. The efferent motor neuron says, let's contract, right? Correct. Well, let's go back to the interneuron. This is an inhibitory interneuron. So the interneuron, so there's 2 synapses here, right? The muscle spindle afferent sends an excitatory message to the alpha motor neuron of the same muscle, the quad, that says, contract. We need to get away from this stimulus, this quick stretch. By the way, this is actually how we get powerful explosive movements, is facilitate the quick stretch. But the stretch, that's the stretch reflex. The reciprocal inhibition part of that is the reciprocal muscle. So in this case, the hamstrings are inhibited through this inhibitory interneuron. So this stimulus right here is a negative stimulus, an efferent impulse to the antagonist muscle. It's dampened, and the signal from the spinal cord to the hamstring, you all know this, is chill out, do not contract, right? Well, what's the importance of that? Efficient movement, right? If we want the quad to contract and we don't want the hamstring to oppose it, we don't want to move like robots, well, then the spinal cord needs to tell the hamstring, chill out. Okay, what's the importance of this? When a muscle is overly active, tight, dominant, its antagonist muscle gets inhibited just by definition through the spinal cord, according to reciprocal inhibition. Hugely important there. So tight, dominant, overactive neck flexors in the forward flexed position leads to weak and inhibited. When these flexors are activated, by definition, the spinal cord inhibits the extensor muscles, right? And those become lengthened and weakened and inhibited, okay? So that's the antagonist muscle inhibition and weakness. This alters normal force-couple relationships and pulls posture out of alignment. So muscle imbalance leads to postural malalignment. Got it. Okay, and we already said this, the muscle length increases in the antagonist muscle because the agonist is tight, dominant, overactive. This alters the ability of the antagonist, in this case, the neck extensors. I'm using my neck because you can see my neck. They become weak and inhibited. Okay, now the last thing we need to learn here is something called synergistic dominance. That just means that muscles that are friends of the extensors of the neck need to help the neck extensors out, okay? So if the neck extensors are weak and inhibited because of the tight dominant flexors, then the friends of the neck extensors need to help it out and they become dominant. Let me go down the kinetic chain and tell you a classic example of this is that when the glutes are inhibited because the tight dominant hip flexors are overactive, when those glutes are inhibited, the hamstrings need to extend the hip. And those people with hyperlordosis, they're prone to hamstring strains. Not the hamstring's fault, it's the glute's fault. But the hamstrings, because they're synergists of the glutes and they both extend the hip, the hamstrings get strained and overused. That's the idea of synergistic dominance. Okay, I talked quickly there, but spend time, go back, listen to this a couple times, apply it to various joints, and you'll see that it's so helpful for you as we try to fix movement dysfunction. We understand it from a muscle imbalance standpoint, then we can start to treat postural dysfunction. Yanda, here's our friend Yanda again. So through studying muscles with EKG, this is really helpful, I think, for us too. He uncovered a predictable pattern in muscles. And so down here in blue font, what I've done for you is dichotomize what Vladimir Yanda did. So what are you looking at? He classified muscles into movement group muscles and stabilization group muscles. And so movement muscles are prone to tightness, dominance, increased neural drive, hyperactivity, okay? Look at those muscles that are in blue font. Now look at the stabilization group, these postural muscles. So postural muscles tend to be the opposite. They tend to be prone to being inhibited reciprocally, and weakness and lengthening and just being dominated by the agonists. Athletic trainers, pre-physical therapy students in the room, occupational therapists, which of these muscles, as you look through them, do you deal most often with in terms of becoming injured and you needing to treat them? I'm just letting you pause there for a minute. When's the last pec major strain that you saw? I bet it's been a while. How about a rector spinae strain? Maybe not quite as long, but when's the last glute medius weakness that you saw? Or peroneal injury, or rhomboids, or posterior rotator cuff? You see what I'm saying? It's these muscles down here, the stabilization group. Let me get out my pointer so you can see this better. This is so helpful for me, at least, because it's these stabilization muscles that are prone to developing inhibition that we most commonly treat. This is tibialis anterior, by the way. That we most commonly treat, okay? And it's these muscles that tend to be tight, dominant, overactive. And so we're gonna learn in a minute that the entire model that we're gonna build this class on is that we need to lengthen, stretch, and inhibit these tight movement group muscles that Yanda identified for us. And then we need to strengthen these muscles that are prone to weakness, inhibition, and altered reciprocal inhibition, okay? And if we do that, chances are that we fix movement imbalances. See this? I just stole my own thunder. So Yanda's classification explains most muscle imbalances seen in the body, and the goal is to reestablish muscle balance by doing a few key things. And this is what the NASM corrective exercise continuum is built on. And I'll say it again, inhibit these tight, dominant, overactive, shortened agonists, and then lengthen them. So first inhibit them. When I say inhibit, what techniques do you use to inhibit muscle? Hopefully you're thinking of like massage and foam roller and right, lacrosse ball, golf ball, tennis ball, etc. You sort of have to beat it into submission, right? You do, and then stretch it, and then you activate the muscles that enter into force couples with those tight dominant overactive muscles. And then after you activate those single muscles, you integrate them into motor programs and movement patterns. So why this order? Can you explain that from a neurophysiologic and biomechanics perspective? I'm not going to explain it for you because I just did in the previous slides, but hopefully you can explain that in the coming weeks. Okay, 2 slides on reciprocal inhibition. The NASM calls this altered, and I underlined that, altered reciprocal inhibition. I really like that because reciprocal inhibition is a normal physiologic process that the spinal cord does, right? But the alteration here is because of the dominance through chronic postural use of agonists, the antagonists become inhibited. And so here you see a classic example of tightness, dominance, overactivity of agonist hip flexors, which pull the spine forward, pull the pelvis forward. What that does is leads to weakness and inhibition in the functional antagonists of the hip flexors, which at the hip is the glute medius, glute minimus, and even to a lesser extent, glute max. And then at the lumbar spine, the antagonist to the iliopsoas is the erector spinae. Hope you're tracking with me. If you need an anatomy refresher, get your anatomy books out. But 3 key terms here. Altered reciprocal inhibition is that relationship that I just said when the antagonist is inhibited because of the tight dominant overactive agonist. And then synergistic dominance, you know, is when the friends of the inhibited muscle need to take over to perform the function of that muscle. Another example might be the gastrocsoleus and the tibialis posterior, which both are plantar flexing the ankle. And then because of these 2 things, arthrokinetic dysfunction can happen, which just means altered joint movements. And here's the example we used. Not going to talk about this, but look through this in your PowerPoint slides, flesh this algorithm out to see how muscle imbalances, the implications of that cause cumulative injury. Let me say a word on autogenic inhibition and then we're done, because we've been talking about reciprocal inhibition, and some of you probably studied out autogenic inhibition in a biomechanics class, maybe when you're doing EMG. But your book talks really a good amount in the lengthening chapter on neuromuscular stretching. And so really the foundation for neuromuscular stretching is autogenic inhibition. So we need to know what that is. We talked about muscle spindle afferents, right? Their role in muscle and tendon is excitatory. When a muscle and tendon get stretched, the muscle spindle afferent is stimulated, and it sends a message through the spinal cord to the alpha motor neuron that tells the muscle to contract, right? This is the essence of plyometric exercises, when we quickly load a muscle so that it can powerfully contract, right? Autogenic inhibition doesn't utilize muscle spindle afferents. It utilizes, and it's more a function of Golgi tendon organs. So that begs the question, what's the function of Golgi tendon organs in a muscle? Some of you probably remember that GTOs live in the muscle tendon junction, and their role in life is to protect muscle from contracting too much and causing injury. So in neuromuscular stretching, what we do is we provide a pretty powerful stretch and contraction, or a stress, I should say, stress, through the muscle tendon junction, and we stimulate the Golgi tendon organ to relax the muscle. So here we go, let's flesh it out. When a Golgi tendon organ receptor is stretched, their signal goes to the spinal cord. The spinal cord sends a stimulus to inhibit the muscle, that same muscle that's stretched, okay? I guess to say it very simply, if we want to stretch the quads, we can contract the quads pretty maximally for 4 or 5 or 6 seconds, usually 6 seconds, to stimulate the Golgi tendon organs to cause them to shut that muscle down. And then we get a better stretch. How does this happen? Very simply, because the Golgi tendon organs override the muscle spindle afferents. So the muscle spindle afferents don't force the muscle to contract. Okay? I hope you got that. You can read through all these bullet points down here or just Google autogenic inhibition. Make sure it makes sense to you. I think it's fun as you as therapists and trainers, as you're doing something called hold relax or contract relax PNF. Some of you know that. You're really tweaking autogenic inhibition and reciprocal inhibition. So it's nice to know those things. Okay, you guys, I am done. Next time, next video is going to be the beginnings of the NASM model for fixing movement dysfunctions. Thanks for listening.